We're ready to move on to the next part of our morning, where we're going to look at another section of the handbook that has been successfully updated, which is refeeding. And Rhys White is going to present to us on that. Thank you.
Thank you, and thank you to the PENS Committee for inviting me to present on refeeding syndrome today. So over the last 2 years, Alison Culkin and I have been working on updating the refeeding chapter of the Pocket Guide, which obviously we heard will be published in March next year. My background is that I'm a dietitian working in London in Guy's and St Thomas's, and I'm also a tutor on the clinical update course. And since 2013, I think it is, I've given the refeeding lecture. So refeeding is of huge interest to me. I find it a fascinating area. So I'm going to just give a little bit of background to refeeding syndrome, set the context of the talk, but I'm not going to spend a huge amount of time on this. I'm going to assume that most of us are aware of this. Look at how we identify risk in refeeding syndrome, and then really talk through some of the evidence, or perhaps lack of it, around the management and prevention of refeeding syndrome. And then I will talk through what is currently going to be the 2018 recommendations for the Pocket Guide. So, disclaimer, at the moment, like I say, this chapter is not quite finalised, so is subject to some minor amendment. So these are likely to be the recommendations, but just to be aware that things could change slightly. I also feel quite bad presenting following Liz's presentation and her very thorough, systematic approach to the energy requirements section, and she presented that very nice table, the very nice pyramid of evidence, and as much as the energy requirements section will be at the top of that pyramid, I'm afraid the refeeding section will be at the very bottom, based on expert opinion. And really the reason for that is the lack of available robust evidence in this area, and if we were to take a more systematic review, we would have no guideline to present to you. So we've had to take a slightly more pragmatic approach, and we have, like I say, made some expert consensus opinions from Alison and myself, as well as getting this reviewed by the PENS Committee. So how do we define refeeding syndrome? And here lies the difficulty in interpreting the literature, because there is no clearly defined definition. It's the metabolic and physiological problems of feeding malnourished patients, and the key factors involved are glucose, magnesium phosphate, and potassium, vitamins, and in particular thiamine, and fluid and sodium. But as I say, there's no internationally agreed definition, and that makes comparing studies very difficult. So just to recap on the pathogenesis of starvation and refeeding. So when someone is being starved, we will rely predominantly in the first few days on our liver and muscle glycogen stores. We see a reduction in insulin as a response to this, and an increase in glucagon. And once those glycogen stores are used up, we're relying a lot on gluconeogenesis from other substrates, in particular fat, and in the more late stages of starvation, protein from muscle. What this results in is protein, fat, mineral, electrolyte, and vitamin depletion, and an intolerance to sodium and water. And then what happens is that we start to refeed these individuals, and the majority of feeding that we administer will have a very large component as carbohydrate as the main energy source. That results in an increase in insulin secretion, which drives glucose intracellularly. Along with glucose, we see an uptake of potassium, magnesium, and phosphate, and a utilization of thiamine as a cofactor for carbohydrate metabolism, and it results, or potentially results, in hyperkalemia, hypomagnesemia, hyperphosphatemia, a thiamine deficiency, and salt and water retention or edema. And that is perhaps the typical refeeding syndrome. If we just look at that at a cellular level, this just shows you some of those mechanisms in a bit more detail. So you can see at the bottom left, we have our insulin driving the uptake of glucose and phosphate and potassium intracellularly to undergo energy metabolism as part of the Krebs cycle, and we see thiamine as an essential cofactor for that. We also get reactivation of the energy-dependent sodium-potassium pump, and magnesium is essential in the conversion of ATP to ADP, which drives that mechanism. So we see the shift of phosphate, potassium and magnesium, or the utilization of those, and as a result of the reactivation of the sodium-potassium pump, we see sodium and fluid move extracellularly. And in a potentially malnourished, starved individual, where there may be some compromise to renal and respiratory and cardiac function, the management and removal of some of this excess fluid and sodium can be difficult and can result in edema and fluid overload. What are the consequences? I'm not going to spend a great deal of time on this. This is part of the current pocket guide, and we've slightly reviewed and amended this table for next year's version. But in particular, what people are perhaps more familiar with is some altered cardiac function, arrhythmia, potential cardiac arrest, tachycardia, and also some respiratory compromise and some neuromuscular compromise, potentially rhabdomyolysis, weakness, muscle weakness, ataxia, and in particular in relation to thiamine deficiency, we're all probably familiar with the term with Wernicke-Korsakoff's encephalopathy, which is an acute condition that can result from severe thiamine deficiency. So that's a little bit of an overview, and now we're just going to look at how we've come up with some of our recommendations. So who is at risk? And depending on the literature you look at, you could literally identify any patient that needs some form of nutrition support to be at risk. This is an interesting systematic review of studies which was published in 2017. Alison was involved in this paper. They present a lot of the literature over the last 20 to 30 years and the risk factors that were identified for refeeding syndrome. And you can see there's a whole array of things here. They've been grouped into themes. So certain clinical conditions we know seem to be a risk factor: anorexia nervosa, Crohn's, small bowel obstruction, dysphagia, bariatric surgery, alcoholism and cancer. And then there are some biochemical risk factors that have been identified, as well as some nutritional support, so calorie intake factors. So there are some studies that report that enteral feeding with 34 calories per kilo is a risk factor, that parenteral nutrition with 20 calories per kilo is a risk factor. But again, all these studies have therefore had to define refeeding syndrome to therefore identify what was a risk. And it's that definition that is tricky. And for example, if you look at the biochemistry section here, a magnesium of less than 0.5, in some studies, a low potassium, magnesium, or phosphate would be defined as an occurrence of refeeding syndrome. This paper didn't necessarily look at it that way. They looked at biochemical and symptomatic refeeding syndrome. So you have to be very careful in how you interpret the incidence and the risk factors, because it's very much dependent on how that study has identified or defined refeeding syndrome in the first place. So NICE, obviously, are perhaps the most well-cited guidelines, certainly since 2006 when they were published. And from my time lecturing on the clinical update course, I always ask how many dietitians have NICE guidelines as part of their local guidelines for refeeding syndrome, and the majority say that they generally replicate these guidelines. So these are probably quite familiar to most people. Remember, looking at that pyramid that Liz presented, these are D-grade evidence, so these are expert opinion. Actually, the NICE guidelines don't use one reference really to support their refeeding recommendations. So it's very short on supporting literature. This is what they say, that patients at high risk are those with one of the following: a BMI of less than 16, unintentional weight loss of greater than 15% over 3 to 6 months, little or no nutritional intake for 10 days, and low levels of potassium, phosphate, or magnesium prior to feeding, or a slightly less severe version of those by having 2 or more of the ones listed below. One of those includes a history of alcohol abuse or drugs, including insulin, chemotherapy, antacids, and diuretics. They also identify a criteria for extreme high-risk patients, which is those with a BMI of less than 14 or negligible intake for more than 15 days. So when we take all that literature into account, there is very limited evidence to be able to support the development of a criteria for identifying patients at risk of refeeding syndrome. a lot of the studies do demonstrate some features of the NICE 2006 guidelines in terms of how to identify risk factors. So in the new edition of the handbook, we are recommending, with the lack of anything better, that NICE guidelines are a useful framework to at least identify the risk of refeeding syndrome, but acknowledging the limitations. We're going to make a second statement that even where there appears to have been sufficient level of oral intake or potentially enteral or parenteral feeding, we also need to give, probably not parenteral, we also need to give consideration as to the extent of any vomiting or malabsorption. So there could be a perceived intake of adequate calories, but if the body obviously isn't able to utilize those, then that patient may still be at risk of refeeding syndrome. Just to touch on what we think are some of the limitations to the NICE criteria, which I've already presented. So if you think of this identifying high-risk category, for example, one of the points is that if any patient has a low level of potassium, phosphate, or magnesium prior to feeding, they are deemed at high risk of refeeding syndrome. Now, there clearly are many other reasons, apart from refeeding syndrome, that a patient could have a low level of any of those electrolytes. So that potentially could over-categorize a whole load of patients into high refeeding syndrome where that actually isn't likely to be the case. In the current version of the Pocket Guide, it's interesting what you realize is in the Pocket Guide when you review a chapter and you read it properly. There's actually what I think is quite a clever statement that was in the 2011 version that prior to, and basically that chapter currently replicates what NICE recommends. But there is a statement prior to this risk criteria that states in the presence of or in the evidence of starvation or fasting. And I think that's quite a good point, that really if you've got a patient that there is no evidence of starvation or limited oral intake or not very severe weight loss, then actually a low level, at which these guidelines don't obviously specify how low is low. Is this just a mildly low potassium, phosphate, or magnesium? That probably on their own, without many other nutritional factors, they probably aren't going to be something that should categorize a patient at high risk of refeeding syndrome. Similarly, in the criteria that looks at two or more of the following, a BMI of less than 18.5 and unintentional weight loss of greater than 10% is a must score of 3. So again, a lot of us as dietitians will receive patients with a referral for a must score of 3, and we might not routinely be thinking, depending on the clinical history, that this patient is at risk of refeeding syndrome. So using these NICE guidance is the only framework that we think is available that's reasonable and practical, but we must be sure to consider the limitations. Some additional considerations that we felt it's important to state in the chapter is that due to homeostatic mechanisms, it is common for serum concentrations of potassium, magnesium, and phosphate to be within normal parameters prior to feeding. So just because those electrolytes are normal, it doesn't necessarily mean that the patient still couldn't be at risk of refeeding syndrome. The next point is potentially more controversial, as we struggle to find what to us seems a logical opinion, but struggle to find some support in literature that's investigated this, is that the presence of ketones in the urine, and particularly in the absence of diabetes, may suggest a period of starvation, which could then work as an indicator as to whether someone is at risk of refeeding syndrome. But we're not going to be able to make that as a strong recommendation, but we will probably be including it as some additional points to consider, because potentially this is something that perhaps as dietitians we could explore, and if we audit in our practice and anyone is routinely requesting ketones to be checked, that we could start to build up a picture of whether this actually does identify itself as a risk criteria. Okay, so identifying risk, relatively straightforward, supporting NICE recommendations, and therefore that's part of the chapter isn't going to change considerably from the 2011 version. But how we manage refeeding syndrome is probably where we're making some adjusted or changing the recommendations. So again, if we look at NICE guidance, again, remember these are grade D evidence. What do they say about managing patients at risk? So they say consider starting nutrition support at a maximum of 10 calories per kilo, increasing levels slowly over 4 to 7 days. Consider restoring circulatory volume and monitoring fluid balance closely. And in those extreme high-risk patients, so those that had the BMI of less than 14 and 15 days of negligible intake, to go as low as 5 calories per kilo per day, and also to monitor cardiac rhythm. So some of the issues that have arisen that are my view, Alison's view, but also have been widely quoted in the literature and in dietetics and nutrition since NICE were published in 2006, is that there's a thought that these guidelines may be quite strict. And there's a concern that obviously some of these patients may be extremely or relatively malnourished, and what we don't want to do is exacerbate the risks of underfeeding and the malnutrition whilst we're managing their nutrition. So there's a fine line in not underfeeding to exacerbate the complications that can occur from that, and also obviously not overfeeding and potentially inducing refeeding syndrome, and obviously some of the consequences potentially could be fatal. So 10 cals is, we believe, quite a low starting point, and over 4 to 7 days is quite a long period to build up to full requirements. 7 days in particular. Again, when I lecture on the clinical update course, I ask delegates to raise their hand as to who takes generally 7 days to build up, and most people don't. So probably at the extreme end, unless there are some significant complications with feeding, it's unlikely that people are complying with this recommendation. It also gives recommendations on what we should do with our vitamins and electrolytes, and in particular, some of the slight anomalies in these guidelines would be the potassium of 2 to 4 millimoles per kilogram per day. I think it would take a very brave dietitian on perhaps the nutrition ward round that decides that they need to put 4 millimoles per kilo of potassium in perhaps their bag of parenteral nutrition. So quite a significant range, and certainly starting at the upper end of that range could potentially be a risk depending on the clinical situation. And the phosphate recommendations almost go the other way. So again, many of us, if we're using the current pocket guide as a way to estimate phosphate requirements, will use 0.5 millimoles per kilo. Yet NICE suggests in even these high-risk patients that we might start as low as 0.3. Now, I know that those of you that manage parenteral nutrition might sometimes struggle to get the phosphate that you'd like into your bags in terms of stability, but obviously just based on what we're recommending in this guideline, we need to consider what is more likely to be an optimal dose. So felt that really 0.3 is probably too low. And believe it or not, there are other guidelines that exist, and mostly that were around prior to 2006. I graduated in 2004, so I have limited experience of these other guidelines, but some. And I just wanted to highlight, so I'm not going to spend a huge amount of time on any of these. In the 1990s, there was Solomon and Kirby that suggested 20 calories per kilo a day as initiation, and the previous pocket guide in 2001 also suggested 20 calories per kilo, and that's the version of the pocket guide that I had when I started working. And I don't remember there being a huge incidence of death by refeeding syndrome when we were starting at 20 calories per kilo. However, in 2006, NICE came out, and some guidelines since then have seemed to follow NICE's approach. So the Stanger 2008 guidelines are pretty much what ESPEN replicates as their guidelines. And again, they do talk about 10 calories per kilo as a starting dose, and to build that up over 4 to 6 days. So very similar to NICE. I did quite like their recommendations in terms of electrolytes, though. They were bit more friendly with the potassium of 1 to 3 millimoles. Their phosphate starts at 0.5 to 0.8, which would seem a bit more relevant to current clinical practice. And they also included, which many previous guidelines had lacked, including NICE, was some recommendation around sodium and fluid intake. So I highlighted when we looked at the pathogenesis of refeeding that circulatory overload and edema was a particular concern of refeeding a malnourished patient. So therefore, we need to give some consideration of not exacerbating or that fluid and sodium overload. And what often happens is if we're giving a very small amount of calories, that normally results in a very small amount of feed volume, and therefore we're asking our medical colleagues to supplement with IV fluids, which is often normal saline, and what happens is these individuals are fluid and sodium overloaded. So I did quite like the electrolyte and fluid recommendations that this study made, and then another paper by Khan, again, very similar guidelines to the Stanger papers. And then just before I go on to what we're going to recommend in the 2018 version for management of refeeding, I just wanted to touch on anorexia nervosa, because this is a very good area to research very malnourished individuals who are at risk of refeeding syndrome, because this is perhaps, in clinical practice, our most truly starved population. And over the last 10 years, and particularly the last 5 years, if you search the literature on refeeding syndrome, the majority of hits that you get will be related to refeeding and anorexia nervosa. And there's a huge amount of work going on in this area, and a lot of publications. In fact, I would say on my desk, where I have, I think, every refeeding syndrome paper that you could possibly find, the anorexia nervosa pile is as big as the non-anorexia nervosa pile. So there is a growing interest in this group. And I just want to highlight some of the numbers, that these are not randomized controlled trials. There are very few randomized controlled trials in refeeding syndrome. I think there are maybe 3. They don't all necessarily look at low versus high calorie feeding either. Some of them are more around route of feeding. But these are studies that have given large quantities of calories to patients who have not demonstrated any level of refeeding syndrome. So this 2010 paper started feeding at 42 calories per kilo. They did, however, supplement majority of patients with prophylactic phosphate. They had no incidence of biochemical or symptomatic refeeding. Golden colleagues looked at a less than 1,400 versus more than 1,400 calorie intake. Again, a bigger cohort of 310 subjects, however, again, retrospective. And if you look at the results, there was a low phosphate, 26% in the greater than 1,400 calories, and actually a higher percentage of hyperphosphatemia occurred in those being fed less than 1,400 calories. GABA, again, 1,800 versus 1,100 calories. Remember, this is a anorexic population, so you're talking about weights of 30 to 40 kilos, so these would be significant amounts of calories per kilo for these patients. Madden looked at 2,400 to 3,000 calories in a prospective cohort study, and again, they gave prophylactic oral phosphate and no incidence of refeeding syndrome. And then more recently, Parker, 58 calories per kilo they provided from the onset of feeding. Again, they gave prophylactic electrolytes. They saw some elements of refeeding syndrome, but they included a rather strict criteria for diagnosing refeeding syndrome. So there was none that met that full criteria, but some that did certainly develop edema and low levels of electrolytes. So I just wanted to highlight that as a group of very malnourished, starved individuals that actually relatively routinely, you could say, across the international stage are being fed much higher calories than perhaps our current guidelines talk about. The caveat to that is that these are non-metabolically stressed individuals, and the majority of us that will work in a hospital or even community setting may be dealing, or more likely to be dealing, with patients with a chronic or acute illness that will have an element of metabolic stress, and we can't therefore completely translate this anorexia data into our hospitalized patients. So, some points to consider. There's lots of evidence, but most of it's weak. Much of the recent evidence is in anorexia nervosa, and the management of refeeding is likely to therefore change across different clinical settings. Prior to 2006, we were a bit more generous with our feeding, and as far as we're aware, there was no increased prevalence of refeeding syndrome. And there is, it's not just mine or Alison's opinion, there is a broad consensus, perhaps, that NICE guidelines, including from Mike Stroud himself, that suggest that perhaps NICE guidelines are overly cautious. So, how do we take all that information and come up with some recommendations? What we wanted to do is utilize the evidence that was available, but acknowledging its limitations, and provide something that was practical for dietitians to take away, but at the same time not giving every answer and every detail that people might like to see, and that some of this needs to be interpreted in your local areas and discussed with your with your own pharmacy and nutrition team colleagues to come up with what might be the most appropriate guideline for your patients in that particular clinical setting. So, what are we likely to be recommending when this gets published in March next year? So we are going to recommend that initiation of nutrition support starts at between 10 and 20 calories. The reason for that is that it's likely to be safe to feed anywhere in that range, given on what we know around previous clinical practice prior to NICE 2006, and also given the context of the refeeding literature that I've presented and other literature. However, in situations where perhaps there are concerns around severity of risk or electrolytes being very low on the initiation of feeding, inadequate monitoring, the Friday afternoon patient on a general ward where there are some concerns about how refeeding syndrome would be managed without the presence of a dietitian, that you may revert to the lower end of this scale. But we feel in general it is safe to feed between 10 to 20 calories per kilo. And then in some places and some clinical areas, 20 to 40 calories per kilo, for example, in the anorexia nervosa population on a specialist eating disorder unit, may be safe practice. We wanted to include some information on how you increase energy provision, which often a lot of the guidelines don't include currently. So where refeeding is initiated at less than 20 calories per kilo for whatever reason, if there is no evidence of refeeding syndrome, the feed should be increased to meet 20 calories per kilo within 48 hours. That's also a guideline within the marzipan guidance for anorexia nervosa. And the point that we're trying to make here is that we know that by using the NICE criteria, we are going to overdiagnose risk in these patients. And therefore, if by feeding a lower calorie intake, we see no evidence of refeeding, it could be that we have over-categorized the risk, and therefore we need to get going and get these patients fed the requirements that they require. However, obviously, if you see an element of refeeding syndrome, such as a significant drop in electrolytes or any physical symptoms of refeeding syndrome, then you would obviously take a more cautious approach in then building up your feeding regimen over perhaps 4 to 7 days in that context. There's growing consensus around the importance of carbohydrate provision in refeeding syndrome, and some of the literature cites a range of 40 to 50% of energy coming from carbohydrate. We know from what I presented in terms of the pathogenesis of refeeding syndrome that carbohydrate probably plays the most significant role in inducing the syndrome, and therefore it's being cautious where possible with the amount of carbohydrate. And therefore, in an oral nutrition support patient, you may avoid juice-based supplements as a first-line form of nutrition support because of their high carbohydrate content. For electrolyte provision, it was very difficult. We're making the recommendations that electrolytes should be provided from the onset of feeding, and this is obviously to try and prevent refeeding syndrome. But to come up with specific criteria on how much and what should be given, there just wasn't the evidence. What we feel is that dietitians should work as part of their multidisciplinary team and discuss doses and routes with their pharmacies and medical colleagues. And like most trusts, mine has intravenous guidelines and oral guidelines for supplementation of electrolyte levels, and therefore we feel it's more appropriate when actually developing your own local guidelines is that you consider what your local policies are in terms of addressing these reduced electrolyte levels. So we did want to include some information and some recommendations on fluid and sodium provision. There are several guidelines, like I say, that recommend 20 to 30 millimoles per kilo in terms of fluid and less than 1 millimole per kilo in terms of sodium. So we have included those as part of our guideline, and that's to try and minimize the risk of fluid overload. This can be a difficult recommendation to make, particularly in perhaps the enteral setting where you're giving a small volume of feed and you do need additional IV supplementation, and actually minimizing, and particularly where you need electrolytes to be provided at a ward level, it may be very difficult to avoid high volumes of fluid accompanying some of these electrolytes. Vitamin and micronutrient provision. Well, the key vitamin that's been reported, I mean, there may be others, but this is the one that's most talked about, is thiamine, and certainly thiamine should be provided from the onset of feeding. However, there is limited evidence to make a specific recommendation on how much thiamine you give and for how long you give it. Some of the guidelines that I presented earlier, the European guidelines suggest 3 to 5 days of feeding. NICE, as you'll all be familiar with, recommend 10 days of vitamin and micronutrient supplementation. So again, you need to look at those guidelines, look at those studies, and decide, what will work in your own clinical area, what's the most clinically effective but also cost-effective approach in terms of provision of those vitamins and electrolytes. And other vitamins and micronutrients should be provided from the onset of feeding, again, but there are very limited evidence to make a specific recommendation on which ones and how much. And we're making a very specific point that what we need and what would really help develop the guideline development for refeeding syndrome is some very strong, robust research, but actually audit data would be almost as useful. A lot of us are seeing patients on a daily basis, and we are categorizing them as risk or not at risk of refeeding syndrome. And then we are providing a feeding protocol based on probably a calories per kilo prescription. And if we were to all audit that data and see actually how many calories are we routinely giving our high risk and our low risk patients, what incidence of refeeding syndrome are we seeing as a result of that, that we could perhaps, as a profession, start building up some more robust indicators of perhaps what is a risk and what is a appropriate management protocol for these patients. Liz touched on this, and this is crucial. You must appraise the evidence. There is some evidence out there, but it's important that we acknowledge its limitations and its strengths where they exist. So consider the relevance of the studies to your clinical population. Really be careful of how papers have defined refeeding syndrome, because that makes it difficult to make direct comparison between studies and also between the different methods of nutrition support that have been investigated. There are different management protocols for those that are deemed to be at risk. So, for example, is the reason that we get away with, or the studies that get away with feeding such high calorie per kilo amounts from day one in anorexia, is because the majority of those studies show that they were prophylactically administered with electrolytes, in particular phosphate. So is it something to do with actually how we administer these electrolytes more routinely than it is around the calorie provision that we provide? Remember, most of the studies, as I say, there is a lack of randomized control studies. They are observational, retrospective studies, and many are just single centers with quite small numbers. But, be aware that what is current practice, where the majority of departments use NICE guidelines as their primary guideline for refeeding syndrome, these are not particularly evidence-based guidelines and are grade D recommendations only, with, like I say, no supporting literature. So, in conclusion, it's strongly agreed that NICE guidelines for refeeding may be too cautious compared with other guidelines that exist. But there is a lack of robust evidence to support any guideline development. Liz mentioned these terms earlier. Do not follow clinical guidelines blindly. So whether that be NICE, whether that be what we are going to recommend next year, it's important that you use your own clinical judgment. We hope that the new PENS guidelines will provide a more pragmatic approach to management, but that some of the available evidence that we present will be required to be interpreted and applied locally. We don't give all the answers. And it's likely that the management of refeeding syndrome requires a different approach across different settings, and that could include the clinical settings such as anorexia versus critical illness versus an acute ward, or it could be around the clinical support that's available. So a very well-established multidisciplinary nutrition team may be able to manage things very differently to a isolated Band 5 dietitian on a general ward. So you've got to consider all those factors when you are making your decisions around how you're going to manage these patients at risk. Finally, I need to acknowledge, I've already mentioned Alison Culkin, who has been a co-author with me on this chapter, and also the PENS committee for reviewing and endorsing the recommendations that we'll be making. Thank you very much.
Thank you very much, Rhys, and thank you, as I say, to you and Alison for all your hard work that's been obviously put into this. We do have time for a few quick questions if anyone would like to ask anything. We'll take Liz at the first, and then the lady behind.
Okay. Just a quick question. I have a problem understanding whether refeeding guidelines apply to people who are having oral diet alone, and the circumstances as to when you might use the guidelines in that particular condition. Partly because my feeling is that when people are ill, they don't eat very much anyway, and they are limited by the mechanisms of the stress response. And so should we be doing that in people on oral diet alone? And is there any evidence? That's the other question I wanted to ask.
So the majority of evidence is certainly in enteral and parenteral feeding, but there is some literature, that including some of the anorexia studies that include patients at least partially orally fed, if not fully orally fed. The recommendations that we will be making, as the current NICE guidelines and many others, are that refeeding can occur and should be assessed in terms of the risk, whether the provision of nutrition support is going to be oral, enteral or parenteral. But I think there's a general agreement that it's less likely to occur in an oral nutrition support group because of the limitations around whatever is causing the poor appetite or intake in the first place, and perhaps unlike where you would prescribe an enteral or parenteral feed, where you can obviously increase the calorie provision as significantly as you'd like to from the onset, that is unlikely to occur in someone that's managing very little orally. On the other hand, there are probably some settings, I have a cancer background myself, so I think of perhaps an esophageal patient that's had an obstruction, for example, that is completely dysphagic for a period of time, who then may have an esophageal stent that suddenly is able to eat significantly more than they were able even the day before, and that might be an example of an oral group that potentially could significantly increase their oral intake quite quickly. So it does apply to any type of nutrition support, but is likely to be less prevalent in a group of oral nutrition support patients.
Thank you. The lady at the back in the black and pink jumper.
Hello, I'm Dorothy from London Met University. I thank you, first of all. I think this is a very well-needed piece of work, and I'm sure not an easy piece of work to have done. My question was actually kind of related to Liz's presentation as well, in terms of the use of using calories per kilogram for the recommendation, and whether you think there's any difference, say if you have an overweight person that's lost a lot of weight compared to having maybe some of those anorexic patients would have been a very low body weight that you're doing that equation on.
Yeah, so good question. And actually, the availability of evidence in an obese setting is very scarce, and the recommendation of the 10 to 20 calories is not really considering someone that could be obese and had lost a significant amount of weight. But there really isn't enough evidence for us to make a recommendation around adjusting that 10 to 20 calorie per kilo recommendation for a heavier body size. I think the majority of patients that are truly at risk of refeeding syndrome will be more at the malnourished spectrum in terms of the lower weight and lower BMI, but it's a very good point which we consider as part of the chapter but are unable to make a recommendation on.
Thank you. Another question here.
Hi, sorry, it's community-based again. Did you make any thoughts about considerations about refeeding syndrome for those extremely at-risk patients and whether they should be always admitted to hospital for refeeding? It's something we find particularly challenging in the community. I'll give you a real example of a colleague of mine of last week. Gastroparesis patient, jejunally fed. Dietitian turns up at the patient's home, hasn't fed for more than 2 weeks, had a couple of yogurts here and there, vomited them straight back up again. And that thought about where do we go from refeeding risk talks to a GP. GP's got no idea whatsoever. You're the expert, you tell me. And would you advise that sort of person sent to hospital in this day and age of trying to keep people out of hospital?
Absolutely, yeah. I'm not absolutely yes. I mean, it's a very good question. Again, some of the reviewer comments that we got was asking us to consider the implications of refeeding in the community. The problem is, as much as I've demonstrated the limitations of the evidence in the acute setting, there's actually a sparsity of data for a community setting. And so we would we certainly aren't able to make a recommendation such as these group of patients are likely to be required to be admitted to hospital. But obviously we're aware that the availability of monitoring in the community, biochemistry, etc., is going to be very limited. And you're not going to get daily bloods on some of these individuals. So it does come down to having to make some clinical judgment. Could you check the urine ketones for that patient to see whether they are demonstrating that they're in ketosis? That could be something to explore. But ultimately, we don't want patients to be admitted to hospital unnecessarily. I'm of the view, overall, having spent a lot of time reading the literature, is that the majority of people that we categorize at risk are not at risk, and that we actually see refeeding syndrome beyond a slight reduction in electrolytes very, very rarely indeed. And perhaps what happens in the community, or what should happen in the community, is where we've given potential range of 10 to 20 calories per kilo, is that you may be obviously considering a much more cautious approach and building up over a longer period of time, given that that availability of monitoring is not there. In your exact example of 2 weeks of no nutrition and a judge feed, I think there would be strong grounds for discussion with medics about admission, but it's very difficult.
GP took bloods, the bloods were fine,
right,
and so therefore said, well, don't need to take any more bloods.
And obviously the initial bloods are probably the least useful bloods. You'd want some of the bloods that come following initiation of feeding.
And it's not just getting the bloods taken, it's the blood results and then the what to do about them, being able to get hold of a GP.
So a plea to all those community dietitians would be, you are presented with patients like this periodically, collect the data on them. What do you do? How do you manage them? Did they refeed? Did they not? Were there any complications? And so that we can start pulling that data together and saying, well, actually, it seems that we fed them in this approach. They stayed at home, and there were no complications, or obviously the opposite. So we need data. We just can't do anything without data, and it's not necessarily research data, as I say. It's just more simple audit data that would be a great starting point.
Another question here. Can you wait for the microphone just so everyone can hear you? Thank you.
I think you've probably just answered that, but what actually, do we have any data on how many people actually do experience what we would classically see as refeeding? What were the consequences?
There was a slide on prevalence, which I took out due to time. The problem, again, in all the literature that reports prevalence of refeeding syndrome is the varying degrees of criteria that are used to assess it. So those that normally assess refeeding syndrome as a drop in electrolytes alone, normally those papers quote anywhere from 70, 80 to 90% incidence of refeeding syndrome. Those papers that look at the classical picture of low electrolytes, some form of clinical symptom, a cardiac respiratory event, and fluid and sodium overload, where you get those three elements in a criteria, refeeding in a nutrition support population is quoted at somewhere between 2 and 15%. So it's very difficult because criteria is so different across those studies.
Thank you very much. Thank you, Rhys.